the free talk. Yeah. And I would like on behalf of the ICC, to introduce our first friend speaker today. Yes. So good morning and good evening. I'm Dr. P.Y. Cho, and today I will give the presentation, not the introduction, with my co-moderator, Dr. Junior Tu. Professor Jordan Swanson is an attending surgeon in the divisions of plastic reconstructive and the oral surgery at Children's Hospital of Philadelphia. Professor Swanson studied the history of science at Harvard College and trained as a physician at the Johns Hopkins School of Medicine. Then he trained as a plastic surgeon at Wash U and the Seattle Children's Hospital, and complete his craniofacial surgery fellowship at the UPenn and the CHOPS. He was also the recipient of the Cho Fellowship in Global Surgery. He also served as Director of Surgical Innovation and Operations IO. Professor Swanson is currently the Linton Retake Indoors Chair of Craniofacial Surgery and an Associate Professor of Surgery at Pratt School of Medicine at the UPenn. He specialized in cleft lip and palate repair, cranial valve and facial reconstruction, veneer maxillofacial extraction, osteogenesis, rhinoplasty, otoplasty, and cosmetic surgery. Without further ado, let's welcome Professor Jordan Swanson with the topic New Approach to Maxillary Advancement. Please, Jordan.
Thank you very much, Dr. Pingan. It's really a pleasure to be here. I'll share my screen now. Is everybody able to see that okay? Okay, terrific. Well, it's great to be here. I do report 2 disclosures. We'll use some images today from our Cleft Care textbook, and I do some educational development for Synthes, but that won't affect the content of the talk. I want to start by wishing a happy Father's Day to everybody. This is the day in the United States we celebrate Father's Day. My own father, I think, has played a big part in a lot of the virtues, the few that I have, but teaching me to work with my hands and to learn to explore. And I have 2 young sons and really enjoy sharing these experiences with them. So to all the fathers out there, thanks for spending a little time with the cleft community today. And actually, coincidentally, I was in Chang last year on Taiwanese Father's Day, which I learned was August 8th. So it was pretty funny to go into the break room with Professor Yu-Rei Chen and see cakes served, and really a privilege to stand next to him and Dr. Lin and others as it was celebrated there. So something that unites us around the world. But that was really a truly special visit for me to get to know the Chang team on the cleft and craniofacial side, on the neurosurgical side. One of their recent visitors to us, I think, will be their 45th faculty member. And just an incredible team that they have created, not just the quality of care in Taipei, but the outreach that they're doing in Dr. Nordoff's legacy in the region. So really a special experience to be visiting you as a professor. And to deepen the relationship that we have with our own hospital, Children's Hospital in Philadelphia. And I'm not a Philadelphia native, but it's really been a terrific privilege to be on the faculty at CHOP. It's a remarkable center that has about 600 inpatient beds, about 40 operating rooms, and really brings, I think, a very unique level of care and teamwork to children's health. For those of you who haven't spent as much time on the East Coast of the United States, Philadelphia is located about halfway between New York and Washington, D.C. And I think one of the things that's unique about CHOP is just the quantity of population that we serve. There's about 40 million people that live within 120 miles or about 2 hours drive of CHOP. And many of the congenital conditions we treat really are proportional to the population served. And I think that has enabled us to sort of build the volume that's enabled us to learn really deeply through our patients' experiences and try to refine the care that we're giving. And it's really been a century of pioneering efforts at CHOP that we come to today. Robert Ivy was a plastic surgeon and a dentist that about 100 years ago really kicked off the program, both for residency training and starting to perform cleft care. And he's known for a number of things, including building a large team and IV loops that some of you may have heard of that we use to sometimes fixate dental or mandibular fractures or put patients into maxillomandibular fixation. He was also a traveler and spent several formative years living and working in China, and was really a deep humanist and created a lot of the foundation for our program that really is centered in outreach. He was succeeded by Dr. Peter Randall, who really was thought to originate the interdisciplinary CHOP cleft team, one of the first ones in the country and in the world. He also was really an innovator, developed new needle holders that enabled the needle to be held at a perpendicular angle, one of the tools we still use today. He was one of the first to describe the cleft lip adhesion as a tool in the cleft toolbox, and worked with Leonard Furlow, who developed the Furlow palatoplasty, but on a number of modifications, like using lateral releasing incisions to really minimize some of the high fistula rates that were seen early on with this repair. So really a remarkable giant that we certainly stand on the shoulders of. And he was followed by Dr. Don La Rosa, who also had an incredible career really as a master clinician and teacher of many of these techniques that we have refined today. It's really a privilege to co-lead the cleft team now with Dr. Oksana Jackson, who's going to be the new president of the American Cleft Palate Association starting in a couple of months, and is a terrific surgeon, also doing incredible outreach work in Ukraine over the last couple of years, her family's home country. And we have a team of 5 other cleft surgeons, Dr. Bartlett, Taylor, Lowe, Liao, and Napoli. And some of the strengths that each bring include maxillofacial and craniofacial surgery with the 2 on the left. Dr. Lowe is an incredible medical illustrator. Dr. Liao is a geneticist and doing much work on zebrafish models that maybe one day will mean that we do not need to surgically treat clefts because we can treat them genetically in utero and prevent them. But really surrounded by a very strong interdisciplinary cleft team of the orthodontics, the speech language pathologists, psychologists, and a cleft nurse coordinator that plays an incredible role in connecting with patients, especially those that have lower resources and difficulty getting into our cleft team. It's really a pleasure to be here today. I think, Dr. Peng Yin, you're really pioneering in creating this webinar. So much of our meetings have been, periodic and once or twice a year. It's obviously very difficult for many people to get to those, and we're all overwhelmed by content and a few busy days. And these webinars have really brought together deep thinking and really kind of united a global community. So thank you for putting these together. And it's really a privilege to be sort of bookended by 2 good friends and role models to me, Dr. Flores and Dr. Percy Russell, who are really together with the 3 of us trying to focus on some deep elements of cleft treatment, trying to go into more depth of some of these more challenging procedures. So without further ado, we'll jump right into maxillary retrusion in cleft lip and palate. And I start from a bias that I think the maxilla is often an afterthought when we're talking about primary cleft lip and palate surgery. And that kind of makes sense because many surgeons that do cleft lip and palate repairs primarily may not be the ones that are operating on the maxilla at a later point. There's also a disconnect because of the amount of time of growth from infancy until the time of needing lip and palate repair, which is really at least half the length of one's surgical career. And when you think about when you're going to be actually treating these kids, there's such a disconnect with timing and a difficulty, and I think the learning that many of us practice week in and week out to try to really refine our techniques based on outcomes. There's also certainly the perception that an ideal initial surgery may prevent the need for any maxillary treatment at all. And actually, a very interesting and memorable conversation I had with Professor Yurei Chen and Chang Gung was him describing the first patient, which I think was in the 1990s, that he was able to treat just with a lip repair, a palate repair, and an alveolar bone graft. And in those 3 procedures, had grown to skeletal maturity with reasonable maxillary growth, and aesthetically and functionally optimal nose. And in those 3 surgeries, did not need anything further. And really saw that as a crucible of achievement, which is obviously such a remarkable thing to achieve. And with all of this, is there really a need to be focusing on the maxilla? I think the contrary view, which I want to really put forth today, is that maxillary retrusion is really an intrinsic element of cleft lip and palate, at least those that have been treated for the last 20 years primarily, and will continue in our careers to require treatment. And part of that is because of Bruce's original work in the 1980s, which showed that looking at about 500 patients, the degree of maxillary retrusion on average was really considerable, 5 millimeters, some slight mandible retrusion commonly as well, which, as we'll get to later, really, I think, forces us to think critically about needs for treating these patients. I want to speak very briefly about avoiding iatrogenic effects on maxillary growth. And the vomerine palatine suture at the central base of the nasomaxillary junction, which I think is really an element of both bilateral and unilateral repairs. And you can see right here behind where this letter B is a critical area to think about in the primary repair. My good friend Edvar Alvarez from Ecuador thinks of drawing an equator because of his Ecuadorian ancestry between the hard and soft palate. And I think this is a useful way that I teach our residents about how I think about reconstructive imperatives, because really the front half of the hard palate is really not as much about function as patency. And I think that because that is where the primary growth centers are thought to be, we really want to minimize and delay the extent of dissection in this area, in particular minimizing open areas that are left to granulate. On the left here, you see a patient, the palate in the center, that has been left with a bipedicled flap on the greater segment over that vomerine palatine suture with a transposition flap from the lateral side. Certainly an important element to consider if just with relaxing incisions that central margin can't be closed, but much less area to granulate than this Vo-Wardell-Kilner type approach on the right, which in many teams has been really associated with very severe growth restriction without really commensurate benefits in speech, as were earlier on thought to be worthwhile with that large pushback. But it's the back part of the palate really where I think the functional elements are. And so that's why I think it's important that as we continue to all collect data and report outcomes in our teams, we talk about palate repairs, not just with what we're doing in the posterior soft palate, whether it's a furlough repair or an intravelar veloplasty, radical or minimal, but what we're doing in the hard palate, because I think that actually plays a really important part on growth. There's certainly a trade-off here of robust tissue mobilization to minimize fistula risk. And I think certainly a message for everybody to hear loud and clear is that it is a priority to create a patent repair. And I think the trade-off should always weigh in the direction of adequate tissue mobilization to get good healing. Finally, there's certainly some discussions of transposing new tissue like the buccinator flap at primary repair. I don't think there's really universal evidence for techniques like that at this point in the majority of cases, but it's going to be interesting to see whether that might help solve this conundrum. But one of the things that we see really across a lot of our cleft conditions is that the initial phenotype or severity seems to be a key driver. This was a recent study that we've been working on with one of our research fellows, Jenny Gung, looking at the influence of primary rhinoplasty of 5-year outcomes. And, our primary goal in this project is comparing primary rhinoplasty to no primary rhinoplasty at outcomes. And we've seen a number of findings that support the benefit of the primary rhinoplasty. But what's really interesting about this, if we look at outcomes, is if we look at the cleft lip severity, this dwarfs components like a primary rhinoplasty as playing a role in primary outcomes. And why I bring this up is that I think that we focus a lot on our surgical interventions, but we need to keep really front and center what is the original phenotype, because for so many of these patients, that dictates the result. Samir Shakir, who is one of our recent residents and now practices in Milwaukee, Similarly did a study with a pretty large sample looking at the severity of the cleft palate deformity and rates of maxillary hypoplasia and need for orthognathic surgery. And similarly showed with regards to the maxilla, both with hypoplasia and need for orthognathic surgery, that there is a correlation between the severity of the cleft palate phenotype and the need for additional surgery or hypoplasia. And this has been shown by other teams as well, the initial severity associated with degree of maxillary protrusion. In a really interesting study written by Dr. Costanza in Milan, who's going to be hosting the European cleft palate meeting next week, is that there's variability in maxillary growth even among similarly treated patients of similar severity. And this is probably something we all see in our practice, but why it's so important, I think, is that we can't treat our way out of the maxilla in a consistent way. And again, it's a reason we need to keep this front and center for all patients. Also, interestingly, this is looking at patient-reported outcomes, the cleft Q, in a report by Dr. Wang in Toronto Sick Kids. And if you look here at the jaw, as well as speech and many other components, if you look at the severity of their original deformity, you get to closer to the center, which is a lower patient-reported outcome score. In other words, patients who have worse phenotypes originally tend to have worse patient-perceived outcomes when they're assessed. Again, a patient perspective on that severity. And this is a recent study led by the Duke team, similarly using the cleft Q. And this looks at patient-reported outcomes over time. And so you look at the jaw deformity, for instance, children that are 8 to 10 have much higher reported outcomes than older kids at 11 to 13 or 14 to 22. So there's this deterioration with time. Again, really important to think about age and how patients perceive this as part of their cleft condition. So I think there's actually a number of recent paradigm shifts in orthognathic surgery that makes sort of today's topic so interesting. First of all, we're moving away from, I think, the idea of a LaForce 1 advancement merely to really critically considering the face and airway and bite when we're considering the need for orthognathic surgery. We're taking aesthetics into view, soft tissue, how can we translate bony changes, as well as using soft tissue refinements like fat grafting and rhinoplasty in order to achieve those aesthetic differences. We're looking at the airway because we know that bimaxillary manipulation has such a profound effect on airway improvement for sleep apnea, in addition to just dentition. We're also employing virtual surgical planning, which gives considerably increased fidelity. We're able to incorporate more corrective elements into our plan. It's enabling better collaboration with orthodontists and even including the patients in our decision-making. And I think makes all of this surgical treatment much more accessible to patients, but also to surgeons who find that these tools enable them to practice orthognathic surgery with perhaps lower barriers than their predecessors. We've looked at some value-based analysis of virtual versus traditional planning, again, trying to be good stewards of our resources and see that they're associated with shorter surgical duration, and the increased implant costs are often offset by decreased OR time and other hospital costs, which I think suggests a value even as we're using maybe these more complex tools. Third is patient-specific implants, which evolved from patient-specific splints that can be produced virtually or with 3D printing to implants that I think have really been a game changer in improving the fidelity of the work we do. We looked at CHOP at our use of these over the last 10 years, and it was really interesting. When the FDA enabled patient-specific implants for orthognathic, we had a very high adoption in 2017, 2018 of those for many conditions, but in particular for any of our bimaxillary surgeries and with maxillary advancement. We've looked at our outcomes using computer-aided surgical planning, and a study of 14 consecutive patients showed dramatically improved consistency at the maxillary level, but quite a bit of variability at the mandible. And I think that's because the TMJ laxity means that the patient's position with that CT scan can vary a bit. And if we use that for our surgical planning, there can be some inconsistency in translating that onto the table. And I'll speak about that a little bit more in a few minutes. We also looked at hardware complications in the area of patient-specific implants. And it's interesting to see that there are higher complications, primarily around infection and exposure. And I think that's probably related to the fact that there often needs to be greater soft tissue dissection and exposure in order to place the cutting guides. in order to facilitate these procedures. There certainly are fewer cases of non-union that we're seeing. And I think that as our learning curve is improving, these patient-specific plate complication profiles are decreasing. That's something we observe. We also observe a tendency toward doing bimaxillary surgery for all of the reasons we've talked about, with our increased fidelity and incorporating many things beyond just advancing retruded maxilla to meet the mandible, and addressing small things like cant that might be affecting the mandible as well as the maxilla. And this is a similar study diagram from the work by Dr. Shakir, showing that the incidence of orthognathic surgery stratified by the A and B angle doesn't show a specific cut point at a certain degree. Between about -3 and 0 or 1 degrees, there's certainly a range of orthodontic or orthognathic approaches for these patients, but certainly a tendency towards leaning towards orthognathic with more retrusion and less likely orthognathic surgery for those with less. In brief, our CHOP protocol that leads up to orthognathic surgery begins with cleft lip repair, often at about 3 to 6 months of age, with or without a tip rhinoplasty, often using a modified molar or fissure type repair. Cleft palate repair has been typically using the furlopalotoplasty in the soft palate, and a variety of techniques in the hard palate as needed for tissue mobilization, generally at about 12 months of age. We typically perform maxillary expansion and iliac crest alveolar bone grafting at about 6 to 8 years of age, and then phase 2 orthodontics beginning at 13 or 15 years of age for girls and boys respectively. And during this time, patients have annual cleft team visits, are undergoing speech therapy, and in certain patients, additional speech-related surgery in the interim. Typically, we think of our orthognathic approach as about a 24-month engagement that begins with treatment planning, both with the surgeon and the orthodontist, to really assess baseline characteristics and determine whether we're going to go in the direction of camouflaging orthognathics for mild retrusion, or whether we are going to decompensate some of the dental compensations to prepare patients for orthognathic surgery, which often leads to about an 18-month period of preoperative orthodontics. Our surgical planning is usually about 6 to 8 weeks preoperatively and comprehensive, with dental impressions that are now typically digital, CT scan, and then often now virtual planning and splint fabrication. And most patients need about 6 months of postoperative orthodontics. We do a surgery-first approach, which I know has been discussed by many of the pioneers in Korea and in the Chang Gung team. For occasional patients, but the majority of patients, we do orthodontic first. Just sharing a bunch of cases, there are certainly orthodontic correction approaches for moderate retrusion. This was a patient with a right unilateral cleft lip and palate. You can see about a 6 millimeter degree of retrusion. And through mandibular premolar extraction, some maxillary dental substitutions, we're able to correct her orthodontically without the need for orthognathic surgery to, I think, a very reasonable clinical result and one that the patient is very satisfied with. This was a patient with fairly mild retrusion, but who had both some bimaxillary retrusion with an SNA of approximately 75 degrees, and similarly an SNB showing retrusion. And so we corrected these with a smaller 6 millimeter maxillary advancement, but disimpaction and clockwise rotation, but also really wanted to do bimaxillary surgery to address that cant and yaw difference. And in doing that, really able to, in short-term follow-up, resolve a lot of those issues. And I should just mention, the cases I'm sharing today are all cases I've done in the last year. I wanted to show sort of some average or typical cases for our work that I might consider typical for the different degrees of severity. This was a 16-year-old female with maxillary retrusion and mandibular prognathism. Similarly, an SNA of 78 degrees, but a fairly normal mandibular position, but for whom we wanted to correct that very flat occlusal plane into a more stable and normal occlusal plane through an advancement and a small mandibular setback, really primarily through rotation, and we're able to achieve really quite reasonable results for her. This is a 17-year-old male with a left unilateral cleft lip and palate, I would say a pretty typical size of moderate retrusion, for whom we were able to do a pretty typical 7 or 8 millimeter advancement of the maxilla. And this is a patient that I think is, again, a great candidate for patient-specific plates, which speeds up the operative time, and which I think also probably plays a role in stability with those 4 linked plates Again, we can plan into the vertical nasomaxillary and zygomaticomaxillary buttresses for fixation, and the patient-specific genioplasty as well, which just speeds up some of that correction of asymmetry as well on the table. Here he is about 6 months postoperatively, just before his final rhinoplasty. And this is a 21-year-old female with left unilateral cleft lip and palate. You can see she has some hypertelorism, some prominent frontal bossing. And although her occlusion on the left looks, quite subtle as far as retrusion, you can see on her lateral ceph not only that degree of bimaxillary retrusion, but the compression of her airway, which again is one of the elements of comprehensive treatment that we increasingly acknowledge in our planning. She had an SNA of 60 degrees that corrected towards normal at 72 degrees and also did a significant mandibular advancement. And I would consider this sort of at the upper level of what I think is reasonable, even with our current technological aids and patient-specific plates as far as an advancement in a patient with cleft lip and palate, hoping to minimize degree of relapse. Again, using cutting guides, and this I really like when we are able to use a bone thickness density map, which again helps us select locations for placement of the fixation plates to really focus on the buttresses of strength and certainly avoid tooth roots. In this model, we use 2 separate maxillary fixation plates, so it'd be easier to position with less dissection for our guides. And here she is postoperatively. A couple other elements that I think are critical to our orthognathic care is our role of our psychologist. And now this is an essential part of preparation and really our acknowledgement of shared surgical decision-making, with patient-centered conversations over the course of years and discussion of the impact on functional and appearance across domains. She's done a small qualitative study at CHOP that yields some interesting findings, and that is that patients who understand how their appearance will change significantly do better as far as long-term satisfaction. Functional outcomes were not as predictive of satisfaction in the long term. Second, patients who had really preoperative understanding of the recovery process, expectations for pain and diet, for example, showed better prediction of postoperative satisfaction as opposed to clinical measures like their degree of pain on pain scales or need for pain medication in that postoperative period. Again, a nod to the importance of this counseling. Speech is also a critical element. And in Dr. Shakir's work looking at long-term outcomes of speech, one of the things we were all surprised to see is if you look at degree of VPD diagnoses and you look across the different interventions, if you look at this right column, the degree of new VPD diagnoses in the time of orthognathic surgery was substantially higher than we thought. Some of us were talking just before the call started about following patients out to 20 or 30 years. I think many teams probably back off on their speech assessment and therapy by the time patients are into double digits of age. But it's a real reminder to all of us of the importance of following speech through orthognathic surgery and realizing there's probably a dose relationship of degree of advancement and effect on speech, especially with on-block advancements. When we look at patient-reported outcomes, which we're just starting to look at in this group of orthognathic patients, what we hear subjectively is, frequently this was the hardest but the best surgery I ever had. For many patients, it's a big satisfier because it so dramatically corrects their bite, facial appearance, and some of their airway concerns. When we superimpose here our small cohort of orthognathic received patients in black over in gray, the reported cleft Q results in the original study of patients, I find it very interesting that their speech and jaw scores tend to be quite a bit higher than that larger cohort, though the rest of their findings are similar. And I think one of the things this might reflect is the fact that at CHOP, I would say we are very vigilant about following their speech and their jaw morphology through skeletal maturity, and perhaps have higher rates of orthognathic surgery or secondary speech surgery. But I think there is a compensatory benefit that patients are demonstrating from this attention. Certainly is going to require more study. But finally, we've done some work looking at layperson perception following orthognathic surgery by crowdsourcing images. And it was interesting to see that many crowdsourced lay people observe increased virtuous personality traits like trustworthiness and friendliness following orthognathic surgery in patients with cleft lip and palate. And when we compare them to patients without cleft lip and palate that underwent orthognathic surgery, there was a greater change or benefit in these perceived virtues in patients with cleft lip and palate. So really interesting as we kind of look at how our patients are perceived with some of these new tools. So as far as sort of state of the art of cleft orthognathic surgery, I think we're seeing consistent and positive outcomes. We observe that many cleft lip and palate patients benefit, but observe this is happening at a difficult time late in adolescence. Could there be a way to beat this decline in patient perception that tends to worsen as kids age through adolescence? And a number of challenges we're seeing with larger movements, especially around stability and speech. So with that, I want to move on to discussing some newer approaches to maxillary advancement that we're working on now. Obviously, there's a number of challenges for severe maxillary retrusion. Do we do a longer advancement and risk relapse? Do we do multiple staged advancements, which patients and surgeons are often reluctant to sign up for? Do we set back the mandible, acknowledging some of the consequences to the airway and to the appearance? Well, certainly one of the revolutionary aspects of our care in maxillofacial surgery is distraction osteogenesis. And for patients like this who did not have a cleft lip and palate, but who had a very large negative maxillary overjet, I think distraction osteogenesis has been a game changer, especially as some of the new internal distractor devices have enabled us to avoid larger red devices, external frames for these advancements. And I think we're able to really increase our fidelity of outcomes with some of these maneuvers. There's been few studies really looking at the impact of Lefort-1 distraction in cleft patients. One randomized controlled trial out of Hong Kong with 47 total patients with advancements of, I would say, quite moderate amounts between 4 and 10 millimeters. And a number of different reports that this team has written up from this same cohort of patients, which essentially shows improved outcomes with distraction osteogenesis in this group with less relapse, as well as improved patient satisfaction. And what's really interesting is if you look at a number of the cleft teams, in particular across the United States, many of them describe that their typical advancement range for cleft lip and palate patients is usually about 6 to 8 millimeters. Beyond that, one ought to consider distraction. But if you look at these same teams, including ours at CHOP, we actually use conventional advancement for many larger movements, really up to 10 or 12 or even sometimes more. Is that because we are finding better improvement in this technology? Or is this just because it's more straightforward for us to do these procedures and it's more complicated to plan the distraction procedures? Why is this? Regardless, we really want to explore further the concept of early adolescent maxillary distraction for these larger movements, with potential benefits of earlier addressing the functional and psychological aspects of severe retrusion and avoiding the surgical burden at late adolescence. But we certainly acknowledge risks, including relapse, as well as pseudo-relapse from lack of maxillary growth when this is done in younger patients, with the risk of additional secondary surgery, and the risks of distraction, including device failure, infection, the fact that these devices can be bulky, they can be painful, and there can be difficult compliance on that advancement. Dr. Costanza did a sample follow-up of patients who had external distraction for a number of patients with sometimes really quite severe advancements in the order of about 2 centimeters, and found fairly minimal relapse in older patients, but in younger patients, relapse rates of about 25% or about 6 millimeters in the long term, which was really quite considerable. We've been working on a number of technical modifications, though, including using VSP for dental root assessment in our osteotomy planning, especially with these younger patients with undescended teeth, device selection moving towards internal distraction when we think it's reasonable, using stereolithographic models to pre-bend plates to increase the fidelity of that osteosynthesis. And in the last year or so, some of the manufacturers in the US actually have begun offering 3D printed plates in titanium that better match the bone, and tooth-based guides that can direct the activation arms so we can obtain vectors with descent and even correcting cants and other asymmetry with the distraction procedure. Dr. Ben Massenberg is just finishing up as our craniofacial fellow this year. He's done a terrific job. And one of the things we've been working on together is really trying to critically assess our patients who have undergone distraction osteogenesis for maxillary protrusion. We've had a series now of 26 patients, a few less than half are female, about a quarter are syndromic, about 2/3 have had a bilateral cleft diagnosis, and about a half have had a prior oronasal fistula repair, again, speaking to the risk of a fistula on contributing to maxillary growth protrusion. And about a third have a diagnosis of VPI, about a third had an external distractor. As far as their cephalometrics pre-op, the average negative overjet was 14 millimeters, so really quite severe with an SNA of about 8 degrees less than normal, but mandibular SNB measures are really quite typical. When we look at our cephalometrics moving from pre-op to consolidation to long-term, we see really a dramatic improvement, about 11 to 12 millimeters, angle degrees of advancement, with about a 20% relapse degree across the whole cohort. Similar effects of the A and B, and again, because we're not manipulating the mandible, we expect no changes there. And we look at our outcomes, the occlusion well past their completion of distraction has about half of patients maintaining a class 1 relation, with about a third maintaining class 2 overprojection early, and about 20% of patients showing relapse or pseudo-relapse into class 3. About half of these patients are undergoing future orthognathic surgery. But what's interesting is us finding that in about a third of patients, they're distracting into a permanent class 1 occlusion. And it's interesting because for all of these patients, we've really discussed distraction as a bridge to final orthognathic surgery, but are appearing not to need that in as many patients as we would expect. And I want to break this down a bit by females and males. And again, looking at these colors, in purple are patients that have relapsed into class 3. Blue are patients who are maintaining a class 1, but have needed additional orthognathic surgery to do that. And in green, patients who have maintained class 1 after distraction only. And what's interesting is you see a significant break point here at 13 and a half years of age. Those younger are generally having relapse or needing additional surgery, but the vast majority over 13 and a half needing just a single distraction into a reasonable final occlusion. With boys, we see a different story, or especially a different break point, where males under 17 years of age all have required additional orthognathic surgery or shown relapse and will likely need orthognathic surgery. About half of males over 17 years of age have not needed additional orthognathic surgery. When we look at multivariate analysis of coefficients affecting this, really considerations like bilateral cleft status or syndromic diagnosis did not play a significant role, but older age than these cutoffs I described, 13 and a half for females, 17 for males, really was the odds ratio of about 25 of predicting that final relapse. So this would be an example of a patient with a bridge to orthognathic surgery at a little under 13 years of age, an overjet of negative 16 millimeters in SNA, severe at 71 degrees. And we see here, after his maxillary distraction, really a substantial correction to just slightly overcorrected. But as he has aged, needs an additional surgery 5 years later, but a bimaxillary surgery of only 2.5 millimeters. And if we think of that original need of 15 millimeters, that would probably not be able to be accomplished in an en-bloc advancement, a very reasonable bridge patient to that final smaller orthognathic surgery. A patient who had distraction alone to just needing orthodontic treatment, finally, again, 14 years of age and negative overjet of 15 millimeters. And we see after advancement her into a very reasonable class 1 position. And as she's reached and surpassed skeletal maturity, really maintaining appropriate dentition without additional surgical need. And a patient who had pretty severe skeletal relapse, a 12-and-a-half-year-old boy with bilateral cleft lip and palate who had had a previous fistula repair, an overjet of negative 13 millimeters in SNA of 70, who underwent skeletal advancement and with distraction, and you can see early on has just barely achieved a class 1 relationship, but has pretty substantial relapse over the following 5 years. And he did a pretty substantial surgery with a bimaxillary advancement of about 9 millimeters of advancement at 20 years of age. Here are these photos just a couple of weeks after his final rhinoplasty, but a patient for whom he certainly needed a very substantial procedure, even at skeletal maturity, despite his distraction. We have tried combining maxillary advancement with SARPI and believe that this can enable premaxillary expansion, or excuse me, maxillary expansion for patients who have narrow maxillas at the same time, and is certainly something to consider as well. What about the speech? You know, we see in patients who undergo mid-face advancement and syndromic synostosis that there are increased rates of VPI, but those often tend to be quite transient using distraction. And a study that was done, or a study of speech in that same Hong Kong cohort, found that 4 of 11 patients with conventional advancement developed new hypernasality. Again, higher but not dissimilar from what we observed with en bloc advancement at CHOP, but no patients with the distraction cohort developing new hypernasality. So I think there is something about gradual advancement of the tissues that may be more optimal for speech. What about mental health? Well, we know that maxillary distraction is more of a burden for patients while distractors are in place. But in a Cochrane review, there was improvement after removal, and the distraction group actually had higher satisfaction with life in the long term compared to conventional. So we're continuing to collect patient-reported outcomes in this group, and it's going to be very interesting to see those and what patterns they show. So to sort of conclude, it's been very interesting to see these very distinct age cutoffs, where for females over 13 and a half and males over 17, I think it may be reasonable to consider a well-planned distraction as enabling the avoiding of additional orthognathic surgery with planning and overcorrection. And so I think that maxillary distraction may replace orthognathic surgery in a subset, but certainly can be considered a bridge to orthognathic for excessive overjet or to normalize face and bite earlier. And again, I think a lot of mandible considerations need to be discussed up front with patients. If there is significant mandible cant or asymmetry, this is obviously something that cannot be addressed just through a maxillary advancement. I want to just end in the last few minutes by talking a little bit about maxillofacial care in low resource settings. And I'm actually extremely excited for the panelists that we have on the call today, each of who have some experience in low resource settings. I really think this is a major need and opportunity, that when we think about where our generation's effect on increasing equity in cleft care is going to be, much of it is going to be around bringing comprehensive care, not just basic cleft lip and palate repair, to many patients. Ben Massenberg, who I mentioned earlier, did a terrific study looking really from a public health standpoint at patterns of cleft disability, and showed that really the prevalence of orofacial clefting is really distributed throughout the world. Slightly higher rates probably based on ethnicity, in Africa slightly higher, in Asia, as some other genetic studies have showed, but really quite universal. But when you look at patterns of cleft disability, these are largely calculated from really calculations of how much lip and palate primary repair has occurred in certain settings over the last 20 years. You certainly continue to see a high burden of care in sub-Saharan Africa, with much better alleviation of disability over the last 20 years in other settings. When you look and stratify by country quintile of income, you continue to see that in the low and low middle income country groups, there's still quite a bit of disability. However, this is, again, disability based on proxies of who has received lip and palate repair. And I think the key point that we are all learning more about is that lip and palate repair gets on base for these patients, but those patients age. And just like you see at the Chang Gung team, or many of the people on this call probably in your own cleft and craniofacial centers, comprehensive care of these patients, speech surgery, speech language care, dental care, orthodontic care, septorhinoplasty, maxillary surgery. This is what takes people really from being largely hindered adolescents to very functional ones. And some dramatic insight comes from Dr. Nicolas Sierra, who's been in Oaxaca, Mexico for the last 5 years with MSI. And they basically came into a site that had had a lot of lip and palate treatment over the last 30 years through some medical brigades, local surgeons traveling to that area, and some periodic care from local surgeons, but where there's been essentially no care beyond initial lip and palate repair. And what they see is that really the results of these patients' age from lip repair in childhood yields very highly variable outcomes. And with minimal additional comprehensive care, there's really high rates of what they term cleft disability among adolescents. And what they found is there really needs to be a very involved, often 2.5-year restoration process for these patients neglected from additional comprehensive care. Why I think this is so interesting is that I think what we're going to see in many low and middle income countries over the next 20 years is patients who have received lip and palate repair in childhood, but little additional care, and are going to have an incredible opportunity or need for additional comprehensive care. In many ways, probably more challenging than the repair we even do in high volume centers because of some of the variability of those early results. And as we focus on outcomes, for instance, in fistula rates, some very interesting studies over the last 10 years have showed that although in the US and Europe, while fistula and dehiscence is often reported at about 2 to 5, maybe 15% of cases, a number of studies really suggest in lower and middle income settings much higher rates of fistulas and complications, again, attesting to some of this variability that Dr. Sierra is seeing. Dr. Morrison and I, about 10 years ago, really talked sort of about the philosophy of how surgery can play a role in alleviating unfreedoms that many patients and especially children experience that translate into disability for them and their families, and how surgical care can yield freedoms. You know, I think that cleft lip and palate repair in children can play a part of this, but if we're really thinking critically, really creating freedoms for a lot of the adolescents we all treat in our own centers is going to really require this comprehensive care being adapted to these settings. I've been really fortunate to be involved in a couple of orthognathic surgery programs in Nicaragua and Morocco led by Dr. Nivaldo Alonso, who's going to be one of our panelists. And in both sites, really an evolved philosophy of patients for whom we are working to complete psychological and psychosocial integration in ways that are patient-driven with an interdisciplinary team, that are locally inspired, and really with the goal of orthognathic surgery being to enable a local team to do this care independently and to work towards that objective. There's a lot of programmatic development aspects involved in launching orthognathic surgery in sites that don't have it. I don't want to focus on that as much for this call. I want to more really focus on a lot of the technical aspects, and I think some of the technical pearls. In the first patient cohort in Nicaragua, for instance, we did a combination primarily by maxillary surgeries on patients primarily with cleft lip and palate, with some international assistance to a local team, with really the goal of showing the proof of concept and obtaining reasonable outcomes in this group that had not had access to it earlier. And a few elements that I think were successful and essential to a roadmap is, first of all, ensuring that an orthodontist is involved with surgical care front and center. And a lot of our partners in that were really critical to this work. Alveolar bone grafting is a first step to really ensure that you're doing orthognathic procedures on as stable and as optimized a maxilla as possible, really starting with straightforward cases such as isolated Le Fort 1s and non-cleft patients as the team really refines their techniques, and reinforce preparation fundamentals. So we really went back to stone models in addition to virtual techniques, ensuring that all the team members really understood these mechanics that for many of us may or may not have been part of our own training, but are needed in those areas. We also leverage new technology and are really fortunate that both from the standpoint of cephalometric analysis and outputs, including for fabrication of splints, we can use 3D technology that makes this less expensive and easier in many cases for teams to learn. And I think there's always a tension between using traditional models and using some of our newer technologies, but as much as we can use this to promote newer technologies, that's how a lot of younger surgeons are learning and relating. A few technical tips: certainly bleeding can be encountered in these settings, and we don't have the medication options like TXA, blood transfusion, anesthesiologist or intensivist experience that we might have as backup at our own centers. And just packing off these areas and going slower, I think, can be associated with less blood loss. Being really careful about subtle things that might be a setback, but could be fatal in these areas, like an osteotome cutting the endotracheal tube. Preventing a bad split, and many of us probably get quite quick with piezoelectric saws or with reciprocating saws doing much of these cuts quickly. I think there's certainly a role for using burrs to make more gradual cuts using hand osteotomes to gradually do the out fracture, to really take time with these maneuvers, because again, a bad split could have a lot more consequences for the demands on a health system. A patient needs to be in maxillomandibular fixation for 8 weeks postoperatively. I think it's really exciting to think about using distraction osteogenesis in these settings. Especially with limited hardware, it can be harder to do advancements that involve disimpaction or substantial advancements with stability. Distraction can be very effective at achieving those larger or disimpacted movements. Also, I think there's a role for surgery first in settings where access to routine surgical theater might be a lot more limited. You have less choice of when you do the surgeries, especially if it's a international collaboration. And so using that opportunities and working orthodontics around it can be very opportune. We need to solve for hardware availability and expense. Leg screws can certainly often involve less hardware demand than some of us like me, who uses monocortical plates for most of my bilateral sagittal split osteotomies. But in using things like leg screws, we have to avoid complications like compression, which can then lead to condylar head displacement. Again, I've seen surgeons who adopt their techniques, but are not as familiar with these techniques and using a minimal hardware approach. We have to be aware of some of these risks. It's also exciting to see some newer studies of the stability, for instance, in this recent cadaver study of wire fixation, that in certain patterns can yield reasonable stability similar to osteosynthesis plates, again, which can help address some of those burdens of hardware expense and adapting these. Certainly, I want to promote an orthognathic surgery chapter in the cleft textbook that uses a number of these techniques and it helps, I think, create a discussion around how to implement some of these. And interestingly, one of the techniques that is talked about in that chapter is IV loops, using wire to achieve maxillomandibular fixation. So I end today's talk circling back with Robert Ivy and my gratitude to how our own CHOP team began about 100 years ago, how much a privilege it is to see a number of friends on the call today and think a little bit collectively about how we can work to advance this for our cleft patients in our own teams and in other settings. But I'm really excited for our panelists here today and look forward to a lively discussion. So we work together forward in a lot of these teams here in Nicaragua and Morocco as we bring orthognathic surgery to new places. And I really appreciate the chance to speak today.
Wow, that was an amazing talk, Professor Swanson. And also congratulations on the amazing results. So now we'll ask our panelists to give some comments. So the first panelist I'd like to invite is Professor Michael Lipka. Professor Lipka.
Yeah, Jordan, great talk. Do you think your age difference in females and males really relates to just end of growth and females being much earlier than males? You know, most girls 14 are mostly done growing anyway. So would you consider just doing a conventional surgery earlier as opposed to a distraction, since you're not needing to do anything further later on?
It's a great point. And I think that probably plays a large portion in this. I'm surprised, though, that the delta between boys and girls is large as it is, because I think most of our skeletal growth maturation data is more like a 2-year difference rather than 4. One of the things we're looking into right now is trying to look in more depth at the actual growth data on each of these patients to see how that might inform that. I still, though, have a lot of reticence on doing a 14 or 15 millimeter advancement, I think, especially in a 14-year-old girl.
Sure.
So I do think that skeletal maturity plays a role, but for some of these cases, that doesn't just translate right into doing an en-bloc advancement.
Yeah, I agree with your how you're doing that. In the younger patient, doing an early distraction as a sort of a staged procedure and doing definitive, it makes a lot of sense to me. I would do the same thing in the patients I see here. I guess it's a judgment call, obviously, in a younger patient doing an early surgery, but I think it has huge benefit. You know, you get them looking quite a bit better, and if you need to do a definitive surgery later, so be it. I mean, we do it all, you know, for transverse discrepancies, doing a STARPy in a staged fashion and then doing conventional surgery later. You know, that's considered acceptable, and we're always sort of negative, well, the patient needed 2 surgeries, but I think it's appropriate in severe situations to do just that. I personally don't like the 18-year-old patient. To me, doesn't that's a patient I don't love doing distraction on. They're ready to go to college and having distractors in place. So doing an early distraction, that makes a lot of sense to me. And then later on, you've got the conventional techniques. So
Thanks, Mike.
Thank you, Professor Lipka. And next, I'd like to invite Professor Alonso for some comments.
Well, Jordan, that's really, I could stay here talking about 1 hour about your talk. It's one of the most complete talk I have ever seen. And you came from a high-income country to low-income country. And it's funny because I live in middle-income country. I would say that's between high and low. And we have different feelings about maybe the same thing. We have a great time together in Morocco, and this is one of the most exciting experience. And I saw here one of the guys watching is Cristiano Tonella from Bauru, that he was there in Morocco, and I think this experience is changing his life. Of course, I have many questions from you from your studies, because one of the points that we work hard is 2 points. And is it possible to avoid orthognathic surgery in cleft patient? And the answer is, of course, is not, because you explain this very well when you show your studies about everything. And the most important is the best surgery I have ever in my life. And that's what we have here. We have a relapse and VPI in some of these patients. We have a number of relapse and VPI, but at the end, some of these patients that we have a relapse in orthognathic surgery, we decided to redo another LeFor-1 advancement, and they say, no, I'm really great, even if you have this not a class 3, but it's in the maxillary is in a good position. I mean, you have just a few things to move the teeth to the position, orthodontic work, and that's it. Most of these patients say, no, I'm doing great. And another thing that work hard is on how we predicted the VPI in this advancement. So when we have some few studies from for Bauru Center that we saw that if you don't have any articulation disorder before, and you have a good mobility of the palate, the palate, so you don't have a high incidence of VPI. But what I would love to focus is in your experience in low income country. And this is one very good point, Jordan. We have this experience in Brazil. We promote the treatment for primary lip repair and primary palate repair. And now we are facing a second and a real challenger is what we're going to do with secondary cases. That's something that we should think about when you have all these NGOs going to countries doing primary lip repair as the solution for the problem. So that's not the solution for the problem. Is a secondary and a huge new problem, secondary cases. We have our friend Gulan, that maybe he's here because he's one of the most interesting guy promoting this cleft lip and palate webinar. And the huge fistulas are our main problem now, much more than orthognathic surgery. I would say that orthognathic surgery is, of course, also a big problem, but it's secondary cases, lip repair, septoplasty, and things like this. So, Jordan, my question is, you are in both, low and middle income country, and you are in the high income country. I saw your plates, your pre-bended plates. This is wonderful, but I would say that maybe I would not have the opportunity to use this in Brazil, man. It's we barely have the regular plates and things like this. But my question is, I saw most of your studies with few number of patients. And what we saw here is like the last year in Bauru, they have like more than 200 in 1 year, around 200 orthognathic surgery. So it's a huge number of different conditions, and you know, my question to you is, what we gonna do for the secondary cases? So how can we work? Like we know very well that Nicholas is doing a great job in Oaxaca in Mexico, and many times he keep calling us to solve secondary problems, and the next steps for him is what in Oaxaca he's living, and what's left there, and what's left in Nicaragua, what's left in Morocco for us. It's the question is, should the high-income country be the center of training for the low-income country? And I were discussing this kind of things, like is it the good place to go to be trained in orthognathic surgery in Philadelphia, man? That's I could stay here for more than an hour, man. You are my very close friend, and I love to make this discussion with you. But would you recommend someone from the Morocco to be trained in CHOP, the best center for craniofacial in the world, man?
Nivaldo, you asked only 15 questions. I want to just take 2 or 3, but I want to turn it to Dr. Fung in just a moment. But I think a few quick answers are, 1, I think the locus of training is in many ways migrating to middle-income countries. Your own center, Bauru, the Chang Gung team have shown that I think there's more similarity to how things are practiced in some of those settings, to low-resource settings, than the gap from high to low. And so even though there's going to be a role for places like CHOP refining some of these more expensive approaches to things with maybe some slightly higher precision, I think there's an incredible role for training centers in middle-income countries. Second, hardware is always going to be a limitation. I'm learning from my orthopedics colleagues working in sub-Saharan Africa that they have in many ways migrated from recycling devices to working with producers in Pakistan and India that are producing them at 1/10 the price. The engineering of a Lefort 1 internal distractor is not rocket science. And even though we want to continue to share these and reuse those and find we can do it safely, I think that's the direction we're going to go. Some entrepreneurs on the call might want to take this as a call to work on some of the production, like Dr. Fayaz has done with instrumentation to support his NGO work in Pakistan. And I think the final question is, we need to focus our work as a community on these complex secondary cases in these settings. We know we're getting better at primary repair as we feed back data on higher fistula rates, on speech data, and know that we have to adapt and do things differently than they have before to get better outcomes. I would love to likewise see deep work that helps empower people, enable people to do these surgeries that they're not seeing at CHOP, because you don't see a lot of fistulas in these higher resource settings. We need to learn from places that are on the front lines. But beyond that, let's turn to Dr. Fung, if that's okay.
Thank you so
Jordan.
much, Professor Alonso.
Jordan, thank you very much.
And now,
I love this talk.
okay. Please, Professor Nguyen.
Thank you, Junior. Jordan, I love this talk. It is, as mentioned, extremely comprehensive and touches upon so many things. And I know we're over time, so I'm going to try and keep it brief. But just 2 quick points. The first one, I really enjoyed that you have highlighted the difference it makes on patient-reported outcomes in terms of some of these orthognathic procedures, it hasn't really been well documented. We have this assumption that just because the facial profile is objectively improved, that the patients automatically feel better. I don't know about you, but subjectively, I've certainly seen some of our patients not necessarily have the direct correlation of facial orthognathic movements with how they've decided to feel about themselves. We actually published a study, I think a year or two ago, doing a regression model looking at the actual movements and what movements correlated with certain domains. And it's actually surprising. Moving an SNA, a piece of an SNA, maybe it helps with cheek convexity, but as far as the patient's perception of profile, it's not necessarily specifically correlative. However, in general, as you have mentioned, it is, I think, a very powerful operation for many patients. So that's the comment. The question for you moves on to more of the global work that you're doing, and I congratulate you for taking these pretty significant initiatives. You've highlighted many obstacles towards comprehensive cleft care, specifically orthognathic surgery in low and middle countries. Part of it being hardware, part of it being knowledge base. My question for you, and I think you've probably encountered this, is how do you make that transition of going from a training model, identifying the partner, and being able to make it truly sustainable, where you are no longer required to be there? You've described some of the early stages of planning, of adaptation of hardware and planning, but have you had, and can you comment on any successes you've had in being able to transition to that capacity building model where you're no longer taking the primary initiative?
That's a great question. And thanks for your comments as well, and that study which you did, which is a great one, Fung. So what I think is the surprise to me is I thought the barrier to making it sustainable would be around technical familiarity. And what I've found is that maxillofacial or plastic surgeons with maxillofacial experience learn the techniques pretty quickly and are quite effective at doing them. It's all of the programmatic support that lets them do it and get the patients to them in their otherwise busy practices. And one of the more gratifying things in Nicaragua is seeing that even though there have been some persistent political challenges that have hampered kind of a broader programmatic work, a number of the individual maxillofacial surgeons, 3 of whom were our kind of trainees in the process, have now started doing this in their private practices, and they're now seeing this as a revenue stream for their own private practices. Obviously, the Venn diagram of their private practice and cleft patients doesn't overlap a whole lot. And so I think that requires the activation of funders, at least in the short term. Dr. Niebecker, I see, is on the call. He works with an NGO and many of the other NGOs that I think are in this space. I would love to see how they think of innovative and creative models of supporting the financing of these procedures by excellent practitioners in this space, because I think that's that bridge that you are getting to. But I also saw, I don't know if any of our Moroccan colleagues are on the call, but one of the Moroccan colleagues is doing orthognathic surgery independently, posted a case a couple of weeks ago that he did on a cleft patient. And I think these are sometimes ways that get less limelight, they get less visibility. Charitable organizations are not giving them visibility because maybe that person is doing the work separate from the organization, but it's still reaching patients, and it's that person honing their craft. So I think it comes down to a person-to-person thing, Fung. And I should just mention for all on the call, Dr. Fung is doing some incredible work in Vietnam, similarly in this vein. And I guess just a plug that we're going to have a couple of sessions at the Milan conference that I think are both going to be in person and available virtually, that are really focused on low resource settings and kind of observing how we adapt some of this work.
You're absolutely right. And I think it's a combination of a couple things. It's the person, you have to find the right partner or partners, and also the kind of cultural and institutional barriers that need to be overcome. So, well, I'm really looking forward to this panel in Milan with some distinguished colleagues talking about how to raise that floor and ceiling for comprehensive cleft care. You know, one of the strategies we found to be a job that's been helpful is, you know, addressing some of the financial things like the IPS software. We're able to help support the purchase of that, but also train our partners so they plan independently. But secondly, you know, it's a private public model where the Ministry of Health is not necessarily going to be invested in developing this and being able to partner in with some private hospitals that have an ability to ultimately turn a profit on this. So to your point, I think you have to embrace the economic realities of the situation in that country, as well as for your partners, to make this sustainable.
If I may say something, one of the important thing is to have a webinar like this, Jordan, or to have a panel like you are proposing in Milan, because you know, we are talking a lot about primary surgery, access to surgery, but at the end, now, or from now to the future, we should emphasize that it's not just a primary surgery, or you should train and educate people to do very good primary surgery, but not just this. We need to think about comprehensive cleft care. It means that it's not just primary. And if we don't have a webinar like this, or persons like you and Fong and all the others exposing this as in this right way, we'll never change the subject. Because if you go to Congress, like Cleft Lip and Palate Congress, and mainly most of them are talking about lip repair technique, or velopharyngeal incompetence, or palatoplasty, or orthognathic surgery as only some kind of surgery, but it's not. It's the end of the treatment. Thank you, Jordan. Thank you very much for your work on this.
Thanks for your comments.
Yeah, Jordan, that was really awesome presentation. Congratulations. You're a great speaker and excellent talk.
Well, guys, this is the work of the community. Let's be honest. I mean, I'm very honest also about the fact that I have not been in practice barely half as long enough for my primary repairs to get to orthognathic age. So we got to work together on this. I mean, it's obvious.
Okay, and thank you once again to all our panelists for this great panel discussion. But at this time, I'd like to go to the Q&A session, because I think there are 3 questions for Professor Swanson. So let us go to the first one. And the first one is actually asking about your opinion on veropharyngeal insufficiency after the Fort-1 surgery. I know you already touched up on some of the basis, but would you like to expand on that?
Just that I think we need to do more study of this. Yeah, I think we all observe in our cleft teams these attrition of patients. A lot of studies you know, will have a lot of their sample start to depart 8, 10, 12, 14 years of age. And I think we would all like to think those are people that are doing well, they're solved, they're treated. But I think the reality is some of the ones that are the hardest to maintain follow-up have many challenges on their own. So we need to try to, as inclusively as possible, study this group to maturity. We have to continue our speech assessment through these procedures. You know, I was really excited to hear Dr. Feng share some of their work on degree of movement and patient-reported outcome findings. I think as this applies to VPI, we need to know more about, is it a linear relationship about how much the movement happens and VPI return? Are there certain thresholds that if we don't go or do go above that level, we can expect it? What about what happens next? Is it a chip shot to do a buccal lengthening of the palate and that VPI goes away, or is it pretty persistent? I think we just need to study this much more, but I hope that our findings that I shared today at least puts this in everybody's mind as something we need to be aware of. So these patients are seeing speech therapists pre and post-operatively from these, and we're trying to look at it more.
Okay, and our next question is asking if the patient has already had sphincter pharyngoplasty or pharyngeal flap. Is there any changes in planning or execution of OGS, and would there be any effect on speech post-op?
I feel a little more confident in answering this one, which is one needs to know about it. The anesthesiologist needs to know about it if there's a PPF there as they're intubating, especially in low resource settings. Second, I think it certainly limits how much on-block advancement, just like having a previous fistula is, in a maxillary advancement. And we talk about this range of what can be done reasonably without relapse. These are patients that I think that threshold of 8 or 9 or 10 millimeters really probably backs down to 6 or 7 or 8 millimeters if they have a PPF in place. The good news is, I don't think that there are deleterious airway issues after an advancement with a PPF or a sphincter in place. I think in many patients, their airway is stable to improved. The other thing is that, a number of studies have shown that if they've had their PPF for a while and their speech is adjusted, you can probably divide the PPF and they still maintain their speech gains that they've gotten. I don't do that as a matter of routine, but I think you can and still have gotten that gain. I think primarily because it's provided a stretch that's lengthened the palate, and some of that will be permanent. I don't know if anybody else, of course, panelists on the call wants to share any opinions if they differ from this.
Well, we have some experience with the maxillary advancement with the pharyngeal flap. And one of them, I need to cut the pharyngeal flap. And I remember saying this in a panel with a speech therapist, and she said that I was crazy. But we need to cut because it was so difficult to intubate the patient. And then I cut the pharyngeal flap. What happened in the post-operative is nothing changed. And we advanced like 7 millimeters. And it was very interesting, but it's very few patients. I have a second patient that we really have some relapse. And one of the reasons that we thought in this was like the same amount of advancement, like 7 or 8 millimeters. I can't remember exactly, but what at the end of this there was some relapse or the maxillary advancement. And we thought that maybe was the limited movement forward of the maxillary, but that's a very few experience. But what we technically I can tell you that's a little bit more stressful to move forward the maxillary after 6-7 millimeters. That's my experience.
I think these pharyngeal flap cases, I think it's just an indicator of how much scar. I mean, you're trying to advance between the pterygoids, right, and pull that forward. Usually a kid who's had a pharyngeal flap, they probably had 4 palate repairs, a pharyngeal flap. It's not common where someone's had a palate repair and a pharyngeal flap and it's like any other case. It's probably an indicator of that was a severe case. The kids had multiple surgeries, I would almost bet, on their palates. And that's what makes it so much harder to advance it, I think. And I think others have shown that it's so much just that scarring in that pterygoid region that's the issue, probably. Not so much the flap itself pulling the maxilla back.
I think you're absolutely right, Mike. I don't necessarily routinely take down P flaps just because you're doing a maxillary advancement. I think you gotta see what the advancement requires and how much mobility you can get. Luckily, I would say the minority of my cases have required taking down P.
Okay, thank you. And then the last question is, if there's already distraction osteogenesis done, or what would the perfect timing for Lefort 1 osteotomy be? would you change the age or like timing for the surgery, or would it stay the same?
Yeah, it's a great question. So the results of our data has changed my thinking about this a little bit. I think for males, maintaining it as old as possible. I mean, acknowledging as Dr. Michael said that, you know, it's not a great time that patients want to undergo more surgeries. They're leaving for university maybe as 18 or 19-year-olds, but I think delaying this all to later points is the right thing to do. What's interesting about this data is historically, I've waited a while on young females. If they had distraction, I still want to get them to that 17 or 18 point where I really feel like they're as well past growth as we can possibly be. But I think the data here suggests, you know, whether it's earlier skeletal maturity, as Mike was saying, or something else, they are at a much more stable point, probably earlier than I previously thought. And so if they have distraction at, say, 14 years of age, maybe, and they need some additional orthognathic, maybe that's at 15 or 16 years of age. One of the things we're actually doing right now, and have a couple of cases in the middle of sort of stages right now, is using maxillary advancement, also doing the mandibular repositioning at the same time, with the goal that the maxilla will end up after distraction in that appropriate occlusion, and at the time of distractor removal, putting on a plate or bending the regenerate. So I think there might be some hybrid approaches here that could even condense that window shorter.
Okay. Thank you. And that should be the last of our Q&A session. So I'd like to turn over the mic to Dr. Tin-Chen Liu for the closing of this presentation.
Hi. So Bunny is catching the flight. And so it's my turn. Thank you very much, Dr. Swanson. And it's very nice to have you today. And actually, thank you for your book you give to us, because right now in our center, we are reading with our fellows on your book. And thank you very much, our panelists today. We hope to see you soon next week. So maybe everybody can turn on your camera and we can take a photo together. Okay.
We'll just give a few seconds while everyone turns on their camera, and then I'll take the photos for everyone.
Well, thanks everybody for putting this together. Thanks to all the fathers who spent a little time together, or as Nivaldo said in Brazil, it's just a holiday like every Sunday. So spending a little time with the gang.
Okay, so I'll start taking the photos now on 3. 1, 2, 3. And I'll go to our next page. We have a lot of people online with us today. 1, 2, 3. Okay, and our next ICC webinar is on July 21st, and that would be Dr. Pierce C. Russell. So we'd appreciate it if you could all join us again for that wonderful presentation that would be coming up. So have a good night, everyone. We'll see you. And happy Father's Day to all the fathers around the world.
Thank you.
Thanks
Thank
so
you,
much,
John.
Junior.
Thank you.
Thank you.
Thank you,
Dr.
Ting.
Swan.
Thank
See
you.
Thank you
Hi,
very much.
Luca. Hi, Giancarlo.
Thank you very much.
再见.
Thanks, Fung. Thanks, Nivaldo.
George.
Thanks, Mike.
Yeah, next week.
wishes.